morning, everybody. So welcome on this second day of the iVS. Today is a dedicated day for the below the knee and the diabetic patients, but we continue with the flow we started yesterday. So we have a nice mix between lectures and cases. We hope some interaction with you all. So I'm happy here to start with my co-moderator, August Isa. So first, we'll have a dive into the diabetic foot clinics and then some interesting discussion for two cases. So I'm happy to invite Vanelli to present how he's working in his diabetic foot clinic, please.
Thank you. Okay. So these are my disclosure. Now, I would like to share with you how we manage a little bit diabetic foot patients. But before starting, it's very important to focus on the pathology, because you know that diabetic patient is the worst condition, and every time this complicates a little bit the characteristic, especially from a clinical point of view of our patient. You see, this is an article that was published many years ago in Lancet. You see that every 30 seconds, a lower limb is lost somewhere in the world. But the worst condition is that we have to consider that 70% of the leg amputation are performing diabetic. So there is a direct correlation between diabetes and amputation. And also these are related, you see, in 85% by the presence of the ulcer. This is a very important key element that I would like to stress to you, because when you evaluate a diabetic patient and there is a small ulcer, you have to run. You have to be very quickly, because we can prevent the amputation if we work very fast in this area. So you see that this is what is reported now. The situation is not very nice for the diabetic patients, because you see that 70% of the people with diabetes are not aware of a complication of a leg or the diabetic foot. That means that generally the diabetologists are talking to them regarding the possibility of improve the quality of life, but very few of them stress that it's important to keep an eye with a lot of attention to the foot. And also that you see that the screening is very low. So less than 30% of patients are able to be evaluated by a full screening therapy. This is also what we do in our department, just to prevent, an ulcer and to prevent an amputation. Remember, yesterday we listened a very interesting lesson about artificial intelligence. And now there are also a couple of papers that talk about the use of AI for diabetic patients to prevent ulcer and to prevent amputation. Obviously, this is something that we cannot start to do tomorrow, but it's something that sooner or later will be part of our life. And where AI could be very important or very useful should be in the prevention, so in the screening process with some specific pathway, but also to provide a personal healthcare pathway that must be dedicated for each single condition. There is also something else that maybe you know, but I have to stress, because every time we are debating with diabetic patients, and especially below the knee, we have to keep in mind that this is a pretty challenging situation, because we have small vessels. Generally, we have long lesions, longer than the SFA, longer than the POP segment, and also occlusion are more frequent than stenosis. I think also in your practice it's very rare to find a flash stenosis in the tibial. Generally, we have a CTO, a long CTO, and also the situation is more complicated because more than one vessel are involved. And in the majority of the cases, we have also a multi-level disease. So there is not only a problem at the level of below the knee, but also in the FEM-POP segment or above in the iliacs. And then, obviously, that there is calcium that is the big enemy for all the endovascular, but also from a surgical point of view. This is what we do generally in our practice. We have a dedicated flow chart with what we call, a diabetic foot clinic. So first of all, the patient is evaluated by our diabetologist that consider if this is a patient that can be a potential candidate for a revascularization. What we do generally, if it is a small ulcer or another problem, we do the clinical test, and these are generally the standard ones. So we evaluate, the ankle pressure, but we know that is something that we have to keep an eye and are not 100% valid, especially for calcified lesion. Sometimes we do a TBI. Or we evaluate the tube pressure and the CO2, the TCPO2 measurement. And definitely, we classify our patient according to the Wi-Fi classification, so we know exactly which patient can be a candidate for endovascular procedure or revascularization. After that, we go through the imaging. Obviously, especially because my background is interventional radiologist, imaging are pretty important. Obviously, you know that this is something that was also underlined by the most recent guidelines that were published in 2019 regarding the use of angiography to evaluate directly the flow. But before doing an angio, we generally perform a duplex scan that gives you some information. Obviously, if we have a patient with clinical symptoms related to also for occlusion or stenosis at duplex, you can go directly to the angio. If not, we perform some more imaging. And this is something that we discuss in a multidisciplinary setting. Generally, we prefer to do CT angio versus MR angio. We know that CT angio was, especially previously, related with a lot of problems or artifacts, so a lot of false negative, because especially when there is a calcium, you can see in this 3D reconstruction, this seems to have a patent vessel, but this is just related to the small size of the vessel with a circumferential distribution of calcium. Nowadays, we have a better possibility with a new software. This is a 4D reconstruction with a very nice reproduction of the tibial vessels, and also we can measure the flow velocity because the flow is different between the center line of the vessel and the sided. And then we can do also perfusion that give us some information about the location and also which vessel we have to work. It is a single vessel or more than one. Obviously, after that, we move for the treatment modality. I don't want to enter in the discussion about, surgical or endo. We have a lot of trials that already debate this aspect. But we are going then to discuss the topic with in the multidisciplinary setting, and we decide if it is a good candidate for the treatment. And all of this is what I would like to stress, we do in no more than 5 days. This is very important, as I told you before, because we must move very quickly between the moment where we perform the diagnosis to the treatment modality. Our goal, to create a straight line forward, bringing the blood flow to the foot. That is something that we know exactly, also because we know if we create a direct flow, this is much better than a collateral flow. Many papers have stressed this concept. You can apply, the direct revascularization that can increase with the angiosome concept or not, but it's important to have a straight line blood flow. And we know that there is a direct relation also regarding amputation rate and the number of vessels patent that can bring the flow down to the foot. What is important and what is also reported that when you have a tissue with a good amount of flow, it's very rare or it's a better, healing process. So this is something that must be kept open, for a longer period so we can avoid the complication rate. How we can treat the lesion, there are a lot of devices, a lot of guide wires, stands, whatever. This is a very recent paper that gives us a little bit of information regarding the technology and the technique. Stenotic lesion, pretty easy, but this is very rare in my opinion and my practice. If we have a CTO, you see there is a flow chart that looks to be a little bit complicated, but it's pretty straightforward. Also because it gives a lot of information about the type of guide wire. We generally start with something more gentle, and then we increase, to be more invasiveness if we need, in case of a complication. Just to show you the case, of a male patient, diabetic, with a small ulcer. You see there was a problem in the posterior tibial vessel. We tried to go straight forward with an antegrade approach, but this was not possible. So we decided to go, from the anterior tibial. It was very nice. We performed a standard dilatation with a 3 mm balloon. You can see here we reconstructed the flow as usual in your practice, and then obviously healing was very nice after 60 days. So in conclusion, what we can conclude, you can use whatever you like in terms of technique or devices, but keep an eye just to keep the foot patent and to the healing the ulcer. Thank you for your attention.
Thank you very much, Fabrizio. It's a great presentation. So I'm going to call to the stage one of my best friends in this business. It's Claudia Herrera. She's coming from Spain. She's going to present us the multidisciplinary approach of the diabetic foot.
Good morning to everyone, and thank you for the invitation for this amazing session. I'm a great fan of all of you, so it's a pleasure to be here. So, as Fanelli said before, this is a very important topic because, as you know, and we all perfectly have seen in the literature, this disease, diabetes, is affecting 537 million people all around the world. And it means 1 out of 10 is affected by diabetes. So, what's going to happen in the future? But nothing is going to get better. So according to International Diabetes Federation, 783 million people will be affected in 2045. So it means a 46% increase. So I was completely shocked when I saw this data. So if we see how the increase is going to be, will be very high in all Africa and Middle East, but in Europe we realized that we are going to see a 13% increase. So we must be prepared and be well informed and trained because this is going to be worse in the future. So diabetes-related foot ulcers have a global prevalence of 6.3%. But infection complicates more than 40% of those lesions, and nearly 50% of those patients that require in-hospital stay will undergo an amputation within 1 year. So the prognosis of those patients is quite poor. If we see the literature, we can compare the death of those patients that is extremely high compared to cancer, for example, lung cancer, which is the most common one. So those patients that are diabetic, they have also an ulcer, and they also suffer PAD. If they undergo a major amputation, probably more than 50% of them won't survive more than 5 years. And if we talk about cost, if we see this paper in 2017, the costs were 3 times higher of those patients that underwent an amputation compared to lung cancer in 2015. So the first step to stop this major amputation of those patients is to create a referral network. Why? Because we must delay any incorrect treatment of infection, also ischemia, and an uncoordinated treatment will lead to a major amputation rate. So it's important to have this schema in your head because it's important to have all of these items bear in mind, because we have to act in all of them. In the literature, we've seen that there are many papers, systematic reviews, and also that are showing that the multidisciplinary team approach is extremely important and is reducing the major amputation rate of that patients. If we focus on the latest version of the guidelines, we also realize that it's very important an early actuation in all the different scenarios, especially when there is an infection, and also they highlight the close follow-up of that patient, because this is a chronic disease. As Ferraresi said in many conferences, for example, he is also emphasizing and highlighting the importance of an early debridement when there is an infection, diabetic foot lesion. And time is tissue as time is brain when there is a stroke. This is our goal. So if we focus on the evaluation and management of diabetic-related foot infection guideline, this is a very interesting review that was published last year. And this is a comprehensive approach how to manage with, when we're facing these diabetic foot infections. And it's highlighting as well the importance of an antibiotic debridement with the blade, and also are incorporating the Wi-Fi classification in this guideline, and also the duration of the antibiotic treatment. But it's also focusing in many aspects that really matters for those patients. That is the close follow-up, the evaluation before having any ulcer, so the prevention, and also what happens with that patient after a minor or major amputation, or if there is to look after the contralateral leg. So in our institution, we created this algorithm a few years ago. We are also updating this, this area, because we've seen, we are incorporating the PAD as well, and other evaluation tests that are more accurate for those patients. So this algorithm has been created because we work in the north area of Barcelona, and primary care are playing an important role to send these patients to us when we must check what's going on and do our proper actuation. So just to illustrate what we are doing in our daily practice, I would like to share with you some clinical cases that for me are fascinating, because we are receiving this type of patients, as you do probably in your centers. But I'm pretty sure that in some other centers, when you receive these patients, probably you opt for a major amputation. But I think we must train ourselves in doing major debridement and wide debridement, because there are options for that patient. This patient, for example, was a type 1 diabetic patient, quite young. He was a taxi driver, and he fell asleep in front of the chimney. And the chimney, well, he suffered this burn because he had a neuropathy. So we did this early debridement. So sometimes we do this in consultation. We don't like waiting for to have the surgical area available, so we just do it as soon as possible. And here you can see the healing procedure that really went well. Another clinical case of a young patient as well. We did also a revascularization of the distal vessels, as you can see. The patient recovered the pedal pulse. And also, at the same time, we do an early debridement. You know that we must do this as soon as possible, but in this case, we do it at the same time. But sometimes you just go for the debridement, and then in 48 hours, you do the revascularization. So under negative therapy pressure, the patient went well, but you can see there is a big defect here that is not going to be covered. So we work with the plastic surgery team, and they did this reconstruction with a skin graft from the groin. This is what they do to plan, and they put this to cover this defect. This is the thermography they do just to test everything is going well. And you can see this is not really aesthetic, but it works, so the patient can walk. Another example of a very severe midfoot infection that also required a wide debridement of soft tissue, and also the fourth metatarsal head amputation. You can see here the healing process and also a skin graft required from the plastic surgery department. So this is important because this young patient also had a major amputation on the contralateral limb, and that's why we must preserve the right one. Another example, this is quite fascinating. You can see here a very extensive defect. So what we did, we wanted to preserve as much plantar surface as possible because there is a high recurrence of ulceration on that patient. So you see that with this wide debridement but preserving as much plantar surface as possible, you see a nice surface completely healed. This is a wet gangrene as well, another example, with cellulitis as well, and you see a very wide debridement. Sometimes they require 2, 3, 4 debridements, but finally we have a nice plantar surface completely healed as well. And that's the last case. That was our last case this week. Was done on Sunday night. And I want to show you this because this is our WhatsApp group of the unit. And that was Sunday night at 9. So it doesn't matter what time. It doesn't matter if it's weekend, because when that patients get into the emergency area, they need an early debridement. It doesn't matter regardless what time it is. So this is our mission, to fight against those patients and preserve the limb. We do weekly sessions with all the components. Here is our team, and here are all the departments that are playing an important role in this diabetic foot unit. And another important thing is that we also do conferences in all the Barcelona North area with primary care to, explain these algorithms and how it works and give them the chance to collaborate all together. And thanks to all this team and primary care and our unit, these are our experiences. We created the diabetic foot unit in 2015, and here is the numbers that we've been achieved with all this effort to reduce as much as possible the major amputation rate. So to sum up, prevention is crucial, but when it's too late, the multidisciplinary team reduces major amputation, and we've clearly seen that. Do not underestimate any lesion, and do not delay any surgical debridement. Thank you.
So thank you very much, both of you, to share how the flow is structured in your institutions. I think it's very important for all of us to reflect now and then on our own structure and how we can improve it. So, questions, remarks?
Very, very beautiful presentation and images just next to the breakfast. I was watching the company guys like, ah! But it's great. Definitely this is our job. So, any questions?
Well, maybe to kick off, I saw very nice imaging in the preoperative workout about flow with the CT scan. I'm not a radiologist. I'm always a little bit, what is your idea about the future? Do you really suggest we should move more into that preoperative flow workout, or just say, still tricky?
No, nowadays with the new software, we are pushing more, because before, obviously, CT angel was not an imaging very useful, because we have a lot of false negative, and accuracy was very low. And also you lost a little bit of time. There was an issue with the contrast media and whatever. Nowadays, we have this new software with a possibility to have this 4D reconstruction. So you have the possibility to have, some vessel analysis from inside. So the system, the software is able to remove the calcium, remove also all the elements that can compromise the diagnosis of the imaging. And then we are able now to evaluate also the blood flow, because what we realized that, as you know, in the center of the vessel, the blood flow is has a higher speed, and on the edges is a low velocity. So this also is something that we consider when we decide also which could be the target for the treatment modality.
Okay, excellent. I would like just to underline the role of the diabetic foot units, because at least in Spain, this is a beautiful box, but we have almost 50 diabetic foot units in our country, but they are usually empty boxes. Because the reality is that we have a lackness of a multidisciplinary approach. The surgeon is not wants to get involved, the orthopedics definitely not. We don't basically have a podiatrics enroll in this sort of unit. So what is the reality in your countries? Ladies first.
Well, yeah, I'm aware there are many diabetic foot units in many countries. At least I would like to talk about my country, in Spain. There are many registered diabetic foot units, but in real life, they're not working properly, or they're not well organized, because it requires a very high effort to organize all the departments that really are important for that. And sometimes it's the uncoordination that really puts you away to start these units. But I think it's not easy. I think there are only like 2-3 in Spain that really works well, despite there are many registered. So I think it's hard to create, but I think it's what we must do. And the combination of plastic surgery, podiatrists that really, care about them, because they need a very close follow-up. So daily, you have the patients in hospital stay. You need to check every day how they are and do, early debridement. So I think create these units is very important.
What about Italy or Belgium?
Yeah, no, we have the same experience, and I fully agree with Claudia that you have to put a lot of effort. It's a little bit time consuming, but the results and the outcome for the patient is much, much better. Because we observe, I think this is in your practice also, many times we receive patients from a referral center, you reopen all the vessel, the foot, and then you miss the patient. And the patient needs to be treated, So this is why we build up this multidisciplinary team with the oncologists, vascular surgeons, podiatrics, and all the people together. And this is also important for us as interventionists, because the team is going to give us also information how much aggressive we must be. Because there are some cases where maybe it's nice just to open a single vessel and that's it. Other cases where there are no other options, so from the discussion is coming out that we have to do all our best, to solve the problem.
Dr. Rose?
Yeah, so a question for the four of you. I want to make a little bit the link to clinical research, studies, and to evidence-based. You see how complex this problem is in terms of, it starts already with diagnostics, with strategy. We see this very complex flow chart, algorithms, whatever. Some people are talking about direct revascularization, indirect foot to the flow to the foot, flow to the wound, flow to the angiosome, multidisciplinary. Some people are with plastic surgeons collaborating, some other are doing it self, extreme debridement, soft debridement, and so on. So is it possible to set up a good clinical trial for BTK CLTI patients? We know that in DCB, in DES, Saval, there are a lot of failures. I cannot believe that this is linked to the devices that are so bad. Is it simply linked on the fact that this is such a complex process, such a complex situation, and that standardization for a clinical trial is simply impossible? What is your comment on this statement?
Yeah, I fully agree. Indeed, flow, we all know, is dependent on inflow, outflow, but also the leg itself. Depending on the status of inflammation, depending on the wounds, depending on the care, the dressings. So I think, and that's something we learned at least the last couple of years, you don't only need a holistic approach of the patient, but you need a uniform approach. I think in a certain center, we always try from the start, from the beginning till the end, to have a uniform flow, independent who's the first contact in that flow with the patient. And I think unless we have some kind of uniformization of the flow in trials and studies, it will be very hard to study the holistic approach, and we will end up always with studying parts of the flow. And there, of course, you end up also with dependency on these parts.
Yeah, I think also regarding the studies that also the endpoints are very critical, because we don't know, we have to look to the patency of the vessel, or we have to look to the healing, because, many times we have maybe the straight line is not more there. We have a huge and nice collaterals, and the healing is, the ulcer is healing. So this, I think, is another key point. And I agree with you that everyone was a little bit disappointed to have several studies that failed, but we don't think that is related to the device. Maybe, there are some other aspects. And I think at the moment we have not the ideal situation, that's for sure.
Yeah, I completely agree, and I think it's more a problem that the end point, I think, is the healing. And obviously the healing will be completely different depending on the presence of an aggressive plastic surgeon. For example, I'm not afraid of doing a wide debridement after revascularization, because I know that in my department there are plastic surgeons that are aggressive with this coverage, with this plastic reconstruction. So we're not afraid of this because we have, like this, we're quiet and calm because they're covering this. So not in all the countries and all departments, they have, this component, this team. And yeah, I think it's hard to do a trial that is more, homogeneous, yeah.
Okay, what do you think? I think probably for the sake of time, we can just jump for the second session. So thank you very much, guys.
Thank you.
I'm going to ask you, Claudia, to remain here. Yeah.
So in the scope of diabetic foot care, there's 2 case presentations to discuss. So the first, I would like to invite Mariano Palena on the floor to present his case. And immediately after the case, we'll have an open discussion with the audience.
Well, good morning to everyone. Thank you for the introduction. And yeah, this is my case of the day. It's a complication in BTK. This is my disclosure, and this is the case. It's a very young patient. I still believe 59 years old patient is very young. It's younger than Marco Manzi, so it's young. Yeah, he's the target. No diabetic, dyslipidemia, hypertension, chronic kidney disease, atrial fibrillation, coronary arterial disease, previous myocardial infarction plus PCA, previous target lower limb revascularization failure plus toe amputation. Patient described as a no-option patient. CLTI of the right foot, Rutherford 6, TCPR2 is very low, is 4, Wi-Fi score is 232, with the user in the previous amputated second toe. This is the endovascular approach. You can see here the image of the previous attempt of revascularization, so the previous access. anterograde access in the common femoral and the ultrasound, 6 French sheath, CO2. Good SFA. So it's a pure below the knee and below the ankle patient. Very young, but heavy calcified. One of those patients that Ferraresi said no option because it's a high grade of MEC 5. The flow is very low, related to a very poor outflow. And here we can just start to imagine what we will find distally, because we can see the calcifications in the arteries in the FEMPOP segment. But FEMPOP axis is patent, no lesions, very poor flow in anterior tibial, so shift for iodium. Peroneal is patent, anterior tibial, multiple stenosis, no posterior tibial. So this is the situation in the foot. First thing, this is a tip of a guide wire. So someone was trying, was failing, and was leaving something in. So when we talk about complications, I choose this case. Unfortunately, I have multiple cases of complications, but I choose it because this is the worst. In my mind, I hate to leave something in, and I hate more when I find something in that was leaving from someone else. So how to move forward? Still options for endovascular approach, surgical, hybrid DVA, or just amputation. One of you who wants to set me the next step, Cum?
In your hands, there is still an option for endovascular therapy.
August, hybrid DVA or DVA? As a heavy calcified patient.
I fully agree with Kuhn.
You fully agree with Cum. Was easy for you, huh? So easy. You know the case. You know the case. Okay, yeah, this is my only chance. So what I did was to try to recanalize this artery. You can see here I was working on those time in Cotignola. So my only O14 guide wire available was the Choice PT. And what I found in was a piece of Choice PT. So with another Choice PT, I was able to pass and to predilate. But it was very difficult to reach the arch, very difficult in all the maneuvers. And still, as you can clearly see now, heavy calcified arteries. Heavy calcified. Seems to have a dominant dorsal circulation compared to the plantar, because plantar is heavy calcified, but it's very thin. No CTO guide wires available in Cotignola, so cut the tip of the Choice PT and create your own homemade CTO wire that finally, after multiple maneuvers, allow me, after multiple times finish out, allow me to recanalize the dorsalis pedis. But the problem here was still the piece of the guide wire in, with many difficulties to dilate, pre-dilate, and still the need to take off this piece. Otherwise, the risk to have this dorsalis pedis functioning was very, very low. The chance to have the dorsalis pedis functioning was very, very low. So, yeah, after multiple attempts, I finally did. Probably I did a short segment of subintimal and finally engaged the arch. And as always, I was finally lucky that my guide wire advanced. So start to predilate, the first balloon was broken. And clearly, with all these maneuvers, I, in some way, broken the artery or damaged the artery, because you can see the amount of contrast out. But, well, yeah, let's say that at that point, also me was convinced that there was a chance to at least try to open this anterior tibia and to have flow in the dorsalis pedis. So predilate everything, 4 French long sheath inside anterior tibial to increase the pushability and to be able in any way to push the balloon as much distal as possible, and to try to be in a good way to finally take off the piece of the guide wire. So after multiple dilatations and pre-dilatation, I was able to advance with this 4 French long sheath that gave me much more support and allowed me to finally pass with all the balloons till the arch. But still, as I said before, the problem to take off the piece of the gate wire. And yeah, at that point, all the balloons cross. This is a 1.5, 2 centimeters, very short balloon that allowed me to pre-dilate the distal dorsalis pedis and the arch. And after this, there was a way. Finally, I was able to have the vessel pre-dilated. So now, good chance to open the vessel. Options: put a stent, surgical extraction, it's not in my hands, leave it there, or an endovascular extraction. To don't waste the time, this is what I did. Advance with the 4 French catheter till the dorsalis pedis, so that the piece of the gate wire was moving. That was the reason why I decided to put a long sheath, but I needed to finally remove it. Inflate the balloon inside the 4 French catheter, blocking the tip of the wire, and remove it. It was much more easier than what you can imagine. If you have a coronaric balloon, rapid exchange balloon, 1.25, 1.2, you inflate the balloon at very high pressure inside the catheter, you block the tip of the wire, and you extract. Very safety, very fast, very easy. And that's it. After this, still need the dorsalis pedis functioning, because you can see a lot of contrast median out. This was what I needed to do, like to be very aggressive with this gate wire, to be able to go down with the big device to extract the wire. So 2.5 millimeters long balloon inflation, 3 millimeters in anterior tibia, and this was the result. Even in a calcified, heavy calcified arteries, in a real SAD-MAC high grade, you can obtain a result, and this was mine with direct blood flow from the anterior tibial into dorsalis pedis, clear SAD-MAC disease because very poor outflow, very poor metatarsal arteries, but even though with good flow for all the toes and with improvement of perfusion for the forefoot. So, anytime we treat a previous treated patient, we can have a nightmare and could need to solve a previous complication. So that's the reason why those patients are the worst patients in my mind. Dedicated devices usually allow us to avoid some type of complications. Here the problem was to use a not dedicated guide wire to try to do the foot recanalization. And a no-option patient is a patient that fails in an expert hands. Thank you so much for your attention.
Very, very impressive. Maybe we do the discussion first?
Yeah,
First?
discuss.
Yeah.
Yeah.
Very impressive case.
It was
Questions?
also for me, so tough.
Questions or remarks from the audience?
You did a great job to remove the fragment or the guide wire. Another option, because this is something that happened, I think, in the majority of the people, is also to use a micro snare. It is, very small and give you a little bit more of safety when you remove it, because you are not going to lose along the way up.
Yeah, honestly speaking, there are many other options. But even if we work in the same country, you are rich, I was poor. So, I mean, I had only 1 or 14 guide wire. I needed to cut the tip to have a CTO wire. What are you talking about, micro snare? Come on, it was not available.
Yeah.
But yes, there are many other options to retrieve this piece of wire.
I think this case perfectly illustrates what you asked before about standardizing and a trial. So how can you standardize this sort of treatment? How many guys in the world can do this sort of amazing stuff? One. So that's the main issue. I think 90% of the cases of SFA or ILS can be dealt by the majority of us, but what about this?
Well, but probably what we have been discussing before with Koum that was not shared to everyone is that it's impossible to standardize diabetic foot therapy. And we continue doing a big effort to center the treatment in the devices rather than to do a patient-centered therapy, because every patient is different. So if you look at this angio, it's 55 years old, 59 years old patient, so it's a really young patient. It was worse than the 92 lady I did last week during Click on live. So since we don't change the focus and center in the treatment in the patient, we are not going to succeed. I believe, it's my personal opinion.
Well, hopefully with the artificial intelligence that we saw yesterday, if we have a uniform flow of taking whatever imaging, pre-op, post-op, and the big data is gathering, we will find some similarities in the flow and be able to evaluate some more.
Yeah, absolutely, fully agree. It can be of a big help, but I'm a really big believer that the flow we will obtain with any type of support will be different for any patient, because any patient is different. The same patient, same age, with the same ulcer can have different vascular lesions. Same patient with same vascular lesions can have completely different clinical situation in the foot. So it's very difficult to standardize the therapy. Much more for SFA and POP, as I was said, but for distal vessels it's very complex.
Any questions from the audience? Can I just, the audience, so we probably have in our institutions our dedicated unit for carotids, for fibro, chiva. How many of you have a dedicated unit for BTK below the ankle, below the knee vessels? So just raise your hands. None. Two. Two. Three. So there's a lot
to do.
to do.
Yeah, a lot to manage, a lot to do. Okay, so let's move to the next case. Claudia.
So that was a 60 years old male admitted to rheumatology, so a young patient as well. Dr. Palena, yeah, is young.
Yeah.
68, yeah, quite young. Okay.
All like Roberto Ferraresi.
Yeah, exactly. So we're going to say he's young, yeah? So he had an ulcer in the right foot due to type 2 diabetes as well. But also this patient had rest pain and several skin grafts from plastic surgery department failed. And that he was a current smoker with diabetes type 2 and also some autoimmunologic disease with cryoglobulinemia and leukocytoplastic vasculitis and Raynaud syndrome. So despite having a proper medical treatment, the patient was not recovered and had these lesions on his feet. So you see these lesions are not very common, so quite weird. We're not having this clinical presentation on the dorsal area of the foot, but the other ones can also be for ischemic. So no distal pulses on any of the lower limbs, and the Wi-Fi classification was this, 222. And you can see that TCPO2 was 31, close to the white lesion. The FEMPOP segment was perfect, no lesions. At the distal area, we could see there was an anterior tibial occlusion with a diameter of 3, and also an occlusion of the posterior tibial artery, but the gray saphenous vein was okay for a bypass. So we did the procedure under local anesthesia, antegrade approach. We leave the sheath close to the below the knee vessels. And also we use continuous perfusion with heparin and vasodilator treatment during all the BTK and BTA procedures. And normally we go with an 018 at the proximal part, 018 wire. But in this case, we prefer to go with an 014 diagonally because we thought with this rheumatologic disease, probably we have a vasospasm. So that's why we went directly with an 014. So this procedure was done in November 2018. You can see the basal angio. no posterior or anterior tibial artery patent, no dorsalis pedal artery patent, and we can see here a posterior dominant peroneal artery. And once we did an anterior tibial antegrade revascularization, the wire went quite well, quite easy, and we see that the arch was okay, no MAC, no SAT, yeah, quite good, arteries, yeah. Because of this disease, this systemic autoimmunologic disease, we wanted to be not aggressive. I always tell the residents that we have that these inflations in that patients must be, I always say, slowly, gently, and softly, yeah, balloon inflations, because if you are really aggressive, you get vasospasm. So we use a 2/80 at the pedal artery, and then a 3/200 in the anterior tibial artery. We try to measure the arteries with a duplex scan first, always when it's always possible. But see, after the angioplasty, it was like nothing. Nothing happened. So what would you do now? Would you go for an open surgery, the vascular surgeons here, or just stop the procedure, schedule for another day, wait, because now we have spasm, just give some medical treatment, infusion, directly close to the lesion? No? No, nothing? Okay. We wanted to keep going.
Well,
okay.
No suggestions from the audience? No. What I personally would do, because this is a strange patient, nothing that we see on a regular basis.
Exactly.
I would put my microcatheter as deep as I can and come back very slowly and giving pushes of contrast just to see, is this really the whole segment, or is this very focal lesions that are, because of the anatomical or
exactly.
problem?
We were quite lost, but we had some information because we know the medical history of that patient. So we were not suspecting thrombus because heparin was okay. We were suspecting probably some spasm or dissection or a combination of both. No calcification on the arteries. So exactly, it was a combination of everything. So we did this angio, and we did sequential, select ultra-selective angios, and nothing was found, just a spasm, we thought. So we did verapamil infusion again, and also we opt for a screwing balloon, like 7 minutes inflation in the pedal artery, the anterior tibial artery, and that was the result. A bit better, but you still see some lesions, some dissections here, even here at the pedal artery. So the flow was not really good as well. The blood flow was a bit slow, but was a bit better, So what happened? We inject from the sheath, and nothing once again. Okay, so that was like 2 minutes later. Then we decided or to continue or to stop. What would you do in that case?
Maybe we do a poll. Who's going to stop?
Stop.
Hands up, who's going to stop?
Change.
Do you still have your cardboard there? Red for stop and blue for go ahead.
Let's stop. How long stop?
Just 10 minutes to stop.
10 minutes.
The time of the coffee and the
Well, so ideas. Okay, so what we did, we saw with a selective angio a flow limiting dissection along all the anterior tibial artery, and we decided to do another inflation, more infusion of verapamil, slowly, keep calm, no rush, and after that, the result was once again this. So that was my face. Okay.
10 extra minutes.
So yeah, I was quiet, a bit upset and tired as well because it was taking too long and nothing was being good. So we said, okay, we have many lesions on that food. We have to do something. Or okay, we stop and we do a bypass. Okay, the Grace of Venus vein was okay. And in a hybrid room, if you're a vascular surgeon, you can just change your mind. But we thought, okay, the pedal artery now is not very good. It's dissected, and we've been, inflating many times. Are we sure this will be a proper outflow for a bypass? Or we just changed we changed the vessel, and we did a peroneal artery angioplasty, because as I said before, it was a posterior dominancy. So, yeah, that was me. Yeah, I wanted to kill myself. After verapamil infusion, sorry, no spoiler, I want to go back.
There's a button.
Go back, please.
There's a button. There's a
Okay.
small button to go back.
Okay, good. Okay, so again, this peroneal artery was treated, but was nothing. Yeah, this is worse than the beginning. So what we decided to do a treatment to do a scaffolding, okay? Because we were pretty sure that that was a spasm, and probably if you stop and you do the angio a few hours later or the next day, probably this angio is completely different if the spasm is resolved, yeah? So what we thought is at least we put an scaffold of this anterior tibial artery because there were dissections in case this peroneal artery is not patent anymore. So we prepared the vessel with DCB because we really believe in an anti-restenotic therapy, especially if it's a vessel, just one runoff vessel that you really need to keep patent for a long time if you have many lesions on that foot. So we left the scaffolding. We don't have proper stents so long for the BTK vessels. We only have the short ones, as you know, with 1A evidence at the proximal part for short lesions. So we opt for this not optimal and there is no evidence on that. But finally, we could had recovered the pedal pulse, and we were very happy because this patient finally healed 6 months later with a pedal and posterior tibial pulse as well from the peroneal artery. And as you can see, let's play the video. That was 3.5 years later. This patient is still walking with the 2 legs. And 4.5 years, almost 5 years later, as you can see in the medical report, this patient still having posterior tibial pulse. Okay, the anterior tibial artery is not patent, as we assume that could happen, but if you open these 2 vessels, at least you have more options if we have many lesions on that foot to have enough flow to heal them. So, many thanks.
Excellent. Any question from the audience?
Yeah, very, very nice case, but don't you think it's a very good case to, from iVS in this case, you go with balloon, balloon, balloon all the time? I think there is a dissection. And to use a in the tibial anterior artery that we do in our institution for link assemblage is very useful to use an iVS, exactly where is a dissection, and maybe move on with a very small scaffolding. We don't have dedicated scaffolding. For me, I use coronary stent in this kind of indication.
Yeah, I totally agree. Well, in 2018, we had no iVS at that time. Yeah, But nowadays we do have, and it will be very interesting to see with exactly where the dissections were. But we realized there were many dissections, not just a focal one in the distal area. If it was only in the proximal part or a focal dissection, I would go just for a short stent, obviously, so and fix it. But it was completely dissected.
Okay, so final remark or question?
No, just to set up a little bit the controversy, I totally disagree with this approach, because you're going to see with iVS dissections everywhere, and especially in the lower half of the anterior tibial. You're going to implant there at the foot, at the ankle, balloon expandable coronary stents. They're going to be crushed in 1 minute. So I disagree with this statement. I think, and I want to hear as a final comment, Mariano's comment on this. At the end, your final picture, final angio, you've seen that the anterior dorsalis pedis flow was much slower than the peroneal and the posterior arch. Was this not? It was definitely a problem of spasm, no doubt about this, but distally also a problem of outflow. And wasn't here, in this case, was it not an option in very expert hands to try to recanalize the foot arch so that you have a better outflow towards the posterior, the lateral plantar arch, and to have a brisk outflow in this anterior tibial?
Yeah, sure. Question. The only remark I can give to Claudia is that I personally believe the problem in anterior was a mix between spasm and acute thrombosis, and it's related also to the clinical presentation. The picture of the foot allowed me to think that could have some problems of distal embolization. But approaching peroneal, I would like to finish the lateral plantar and arrive in the arch, because it could be much of help. Finally, you succeed in the clinical situation. That is the most and the only important thing. So, well done.
Yeah, I agree. I agree with and thank you for the comment, because we only did the proximal peroneal angioplasty, but yeah, will be great.
You succeed. This is the most important thing.
Okay, so 2 very nice cases to illustrate, yeah, still a difficult pathology. Thank you all for this session. So I think we'll be back in 20 minutes for the next part. Okay.
So, hello, welcome, come back for this new session, and a very interesting session with some more practical tips and tricks for below the knee, below the ankle, revascularization, treatment algorithms, and so on. So, first, before we jump into the scientific program, and before I invite the first speaker, you can raise up your cards, whatever the color. Who has experience with below the ankle revascularization in the room? So not below the knee. Below the knee, I think everybody is doing this, so now and then, whatever, but really below the ankle. So raise your cards. So like 2/3 of the auditorium. Good, perfect. So I'm sure even these 2/3, they're gonna learn a lot of tips and tricks from the key opinion leaders we invited today. And so it's my great pleasure and honor to ask August Isa on the podium to show us step by step how we need to do a perfect below the ankle recanalization.
Thank you very much for your kind invitation and your introduction. It's really great to see you still alive, regardless yesterday night. So these are my disclosures. And let me start asking you, how many of you are just still following the angiosome concept? So red one, yes. Blue one, no. Oh, a lot of followers. Okay, so let me tell you that I'm not fully convinced about the angiosome concept, and because mainly the majority of our patients are diabetic guys with chronic kidney disease, and this causes a sort of remodeling of the vasculature, which entails a loss of the choke vessels and usually following minor amputations. But moreover, you have a look to these anatomical variations described by Mariano and Marco. This is basically not described on the angiosome concept, and also the majority of large wounds involve more than one angiosome, which probably just makes your life a lot more complicated. But at the end of the day, also in the Taylor and Palmer description, basically there wasn't described nothing about the BTK vessels or the plantar arch. So that's why I don't really think that this angiosome-based revascularization is the same that a wound-based revascularization. And we are nowadays talking about this, trying to bring flow into the wound. Because we know that direct revascularization decreases the wound healing time, increases the healing rates, and also increases the limb salvage rates. So you may probably think, this is cool, theoretically, super sexy, but show me the money. I'm going to show you. So this is a case of a lady with an orphan heel. As you can see, on occluded SFA, diseased anterior tibial, no really nice vessels at the level of the foot. So what we did initially is just try to recanalize the SFA and the anterior tibial. And as you can see, we even just reached the DP, and there's a nice plantar arch. But the clinical outcome was not so good. And as you can see, the wound at the level of the heel was not improving basically well. So that's why we decided just to go for the posterior tibial artery. And initially, we went down, drilling, but perforation. So we thought, well, DP is patent, go to the plantar arch, whack, perforation again. Wow. So what would you do? We have a perforation in the dorsal system, a perforation in the plantar system. So, cardboard. Would you cry and pray, red? Or would you go for a Buzz Lightyear? And you may probably wonder what on hell is a Buzz Lightyear? It's going to the forefoot and beyond. And we went for a Buzz Lightyear, which we basically punctured the plantar arch, and we were lucky enough just to engage the lateral plantar, recanalize the posterior tibial, and following balloon dilation with a luminor 2.5, look, this is a nice outcome, nice breeze flow at the level of the foot. This is what we call zone 3. And this is the clinical outcome. We basically achieved complete wound healing 3 months later, TCPO2 raised up to 60 millimeters of mercury. This is what we call about the wound sum concept. Second case, this is a case of an acute diabetic guy with an abscess at the level of the foot. And if you have a look to the angio, we have a tight stenosis at the level of the anterior tibial, diseased vessels distally, really none vessels at the level of the foot. So we initially tried to recanalize, as you can see, the anterior tibial. We crossed through the lesion quite nicely, and then we arrived to the foot and perforation. So perforation, no vessels at the level of the foot. What to do, guys? Raise your cardboards, bread, pray, and pray. Anyone for a Buzz Lightyear? Blue ones? Come on. Be brave. Good. So that's what we did. We went for a Buzz Lightyear. We punctured the digital artery. We were lucky enough just to engage the digital artery. We put a Sargent 014 catheter to secure the access. And then, as you can see, we arrived into the DP with a 2 millimeters of sternoballus. We opened a gate for the anterior wire. This is what we call the CAR technique. And once the gate was open, the anterior wire was able to cross into the DP and even into the digital artery. So 2 millimeters of sternus balloon to achieve hemostasis at the access point, 2.5 luminor on the DP, 3 and 4 for the anterior tibial. And look, nice breeze flow at the level of the foot. Not only on the lateral view, but also in the AP view. This is the wound blush. And this was the clinical outcome. We achieved complete wound healing, again, 3 months later, TCPO2 up to 60 millimeters of mercury. This is cool, isn't it? Okay, this is one of my favorite ones. This is a guy with amputation of the 3 toes following an abscess, distal pulses. So how many of you consider this an ischemic guy? Distal pulses, DP pulse. So if you have a look to the Wi-Fi classification, it's where? It's not anywhere. the reason for the non-healing amputation is on the angio. You can see a patent DP, also even the arch, but we have an orphan area on the lateral aspect of the foot. So what we did, we basically recanalized the tarsal artery with our wire. Here we are, then 2 millimeters of Zenus balloon, and even we cross into the lateral plantar with the wire. And at the end of the day, this is the outcome. Blush at the level of the wound. And blush entails granulation tissue, and granulation tissue entails complete wound healing. And this is exactly the same when you have a plantar arch disease. Again, a patient with distal pulses, non-healing toe amputation. Why? Have a look to the angio. You see, you have a patent DP, but you have an occlusion of the arch. So what we did is just to recanalize the arch, the Oceanus 2.5 millimeters, and following this recanalization of the arch, we have blush at the level of the wound, complete wound healing in 1 week. And as in this case, third toe amputation, non-healing amputation, and again, the reason was on the angio. We have an occlusion, a partial occlusion of the arch, and we have this tiny collateral fit in the arch. So we tried initially to cross anteriorly through the arch, but we failed. So we thought, why not just to go transcollateral? So we take advantage of this collateral, get back in a roundabout way, and we were able to recanalize, as you can see, the arch, balloon dilation, and once we had the gate open, we go ahead with an anterior wire into this plantar arch, and even in the lateral plantar, and following the balloon dilation, as you can see, beautiful, beautiful outcome. And this, again, entails complete wound healing in 1 week. And let me just finish underlying the importance of the multi-wire approach. So this is a case of a patient with an occluded anterior tibial, occluded posterior tibial, reconstitution in the medial plantar. So we initially tried just to recanalize the lateral plantar, perforation. But we were lucky enough just to end up in the medial plantar, and from the medial plantar, we went into the first metatarsal, get back into the DP artery. You will see this nicely in the AP view. This is transcollateral to the DP. And we just tried to recanalize retrograde the anterior tibial, but we didn't have enough support. So we decided just to puncture retrograde the DP using the wire as a landmark. We progressed our wires, you can see, quite nicely, but some stage we got stuck. We were even unable just to progress a small caliber balloon, ultra low profile. So we decided just to try to puncture the DP anteriorly, and for this we use our technique, the balloon-assisted technique. And as you can see, we were lucky to achieve the antegrade axis, and from the antegrade axis, we basically recanalized the plantar arch. As you can see in this image, here we are, end up into the lateral plantar artery. And following this, we perform our balloon dilation before we basically need to perform the rendezvous, as you know. This is a 2.5 Oceanus balloon for the lateral plantar and the plantar arch, 2 millimeters for the medial plantar, 3 for the distal posterior tibial, and 4 for the tibioperoneal trunk. And look, beautiful, nice breeze flow all over the track of the posterior tibial, lateral plantar, and medial plantar. So, in conclusions, let me tell you that BTA revascularization is safe and feasible and should be considered in specific clinical conditions. You need to master, you need to be familiar with the anatomy, because otherwise you will get lost at the level of the foot. Also, it's crucial to have dedicated devices and to master the bailout techniques. And really, really important is just to keep on pushing, because at the end of the day, you are CLI fighters. And please make me happy. So how many of you are still thinking about the angiosome concept, red cards? Or how many of you are aiming for the woundsome concept, blue cards? Excellent. So for those two who are still thinking about the angiosome concept, I strongly recommend just to read this. This is about to be published in the Journal of Endovascular Therapy. 100 key opinion leaders of the world just aiming for the woundsome concept. Thank you very much.
Thank you, August, for the fantastic presentation. Let's continue This is the time for Nicolas Luis, the algorithm approach to cross different lesions.
Hi everyone, very happy to be there. It's a meeting with a lot of discussion, a lot of interaction, maybe a lot of fighting. My algorithm, why they asked me to give you my algorithm? Because in my small center, in small town, in the south of the French, we have a huge experience since now 10 years. My algorithm is very simple. It's based on what I learned since 10 years to analyze the preoperative CT scan, to have the good CTO technique that I learned with the Japanese technique, with the cardiologist, with the radiologist, and at the end, to have the appropriate device to perform the best case. Why don't you use the CT scan? Key point of the CT scan is the best. You can choose the best access, analyze the angulation, the length, the diameter, the calcification, and you can anticipate all the strategy. For me, it's mandatory. We have all now some nice hybrid room, and you can push the limits. It's 10 years now. We can create a bridge, we can line up a center line, we can draw planning circle inside the calcification, we can modeling all the calcification, and you can recording the best recognition angle. And at the end, you can work like this if you take few time to perform this kind of technique. We present in the major congress this approach. We have our results. This is all results, but what can we see on this result? We have the same. When we go directly navigate with no redirection, it's the same that in the literature. And we have the same to avoid a retrograde approach. And it has been published. Now it's clear. You need to perform fusion imaging. You need to have a CT scan. We have two approaches. Me, I want to stay antegrade, and you will know why I want to stay antegrade. Because you can do that. You can handle tiny spaces, you can go fast, you can very good, and at the end, it's very elegant. And you have the other technique, the retrograde approach. It's quite the same at the beginning, but now, you can destroy everything, you see a lot of cases. Okay, for sure, you will stop one time. On the artery, it's not an artery. It's what you want, but for me, it's not an artery. This guy will stop, and we need to reconstruct everything. I was joking. Why I want to stay in endoluminary way all the time, the majority of the time? Because we know that the last enemy is the calcium. From the different study, we have bad results when we see this kind of study. In the very, very high score calcification lesion, our results are very poor, independently to the longest of the distance that we have. That's why I want to keep, in transluminary approach, to keep free the possibility to use the dedicated calcium therapy. No? It makes sense. And expected to have better patency in the calcium, in the calcification lesion. For that, you need to have a selection of your good guide wire. You can read after. You can form your guide as you want. And you need to know the different technique. You need to take time. For me, CTO means humility. I start a long time ago with the sorting. I try, I learn. I go everything working with this technique. And it's humility, because sometimes it's good, but not. And you need to know exactly to do what you want to do. Okay, we need to have an algorithm, but an algorithm is good, but we need something else with the algorithm. You need to have a CTO difficulty score, because to put this basket at 6 seconds at the end, don't know if you remember this game, only Michael Jordan can do that. Some guy can do that if they lead 20 points at 10 minutes at the end of the game. The CTO difficulty score is quite the same that we can have in coronary approach. We can analyze the access, the proximal cap, the distal cap, the length, the diameter, the calcification, and also when you see a prior attempt. Prior attempt is very bad because dissection is everywhere. And it's simple, 1, 1, 1, and at the end, you can, with this score, anticipate the device that you need. Access. Access is very important because access is the stability. On what I learned, when I want to start a CTO, I need to have the best stability that I want. Severe obesity, pre-European surgery, acute aortic angulation, brachial or radial access. For me, it's complex because we don't have yet now all the dedicated device from the brachial access or the radial access. Key point, stability. And when my friend Jan trying with his boat to go away, if you don't have a stability, it's impossible. Okay, what means stability? When you have this imaging on fluoroscopy, you know you can perform a good CTO. You need to have an escalade, the good introducer. You can use a guiding catheter, a support catheter, or a micro catheter. And with all this escalade, you can have very good support to try to have a very good recanalization. The first case, this old woman, she has a prior access. She has stent everywhere. She's obese, 20 meters, because they cut off the surgery with the profunda. And the only option that I have for this woman, very, very difficult lesion. I have only option from the arm. She was obese. I do the cut down of the artery. And what I say, you need to have support. Perform the CTO like this, okay, maybe you can. And I give you the time clock of the CTO. Okay, we move on, we change from another guard wire, we end dissection, but with the modelization of calcification, I came closer, around 25 minutes after. I perform this kind of angio. There, I'm working, I try to have another direction in this very calcified lesion. And it's not so bad. And here, 25 minutes after, I'm not so far. And we move on with an Albert 018. Okay, it's good. But I don't have any support. And my microcatheter cannot cross the lesion. Okay, and I take a long sheet. You see, a guiding catheter, and now it's very simple. To have the pushability to cross, because I want to change for a small, soft guide wire. And I'm very happy that we're coming very soon, the new long shaft to perform very complex cases from a upper approach. The second point is the analysis of the proximal cap. You need to use your favorite soft wire to go very close to the CTO, evaluate the proximal cap with tooth angiography, always perform an angiography that I saw you just before crossing the lesion, and after you change to avoid any damage of the distal part of the artery. Everybody told me about the sequence of wire escalade. Okay, you have different kind, soft, intermediate, stiff, very stiff, and you need to, you can have this algorithm when you see on the preoperative CT scan. But for me, what is also very important, it's not the antegrade wire escalade, you know that, but you need to have the desescalade sometime to cross the distal part of the artery. And when we have the distribution of different wires that we have, and I will be a liar if I've told you I've only used one guide wire. No. In simple cases, we perform one guide wire in 44% of the case, two guide wire in 25, but sometimes we use 3, 4, 5, 6 guide wire. You need to know exactly which guide wire you need to use. For example, this one, proximal cap tapered, very simple, not long lesion, but the distal part very calcified. And what is very interesting, I show you, you perform angiography just before crossing the lesion, and this is the help of the fusion imaging. You can see the guide wire bends on the calcification. You know when you want to go. Okay, you can perform without fusion imaging, but for beginner, it helps you to know exactly where you want to go. Yeah, you try, it seems good, no, another calcification, you pull back, and we redirect the guide wire in the good position. Okay, good. It's finished. 5 minutes. Length and diameter. In my daily practice, when we have a long lesion, I always use a microcatheter in 0.18 or 0.14. When it's small artery, an SFL less than 4 millimeters, I'll start with a 0.14. Yes, small guide wire, small mistake. Big guide wire, big mistake. And now, we need to have microcatheter. For example, we have support catheter, but a 6E is not a microcatheter. It's not have the ability to have the pushability on the torque like we do in coronary artery to navigate. On the surgeon, for me, I can use in 80% of the case because we have a proximal part and a distal part totally different, adapted to our daily practice. Calcium. I want to stay in good luminance to have the best therapies I can use. We are working on the fusion imaging. We're working on the analysis in our center of the volume of the calcification. On this guy, small lesion, very short, very difficult, very calcified lesion. Okay, I want to use the debulking. I don't want to use a stent or a balloon inside. I want to stay in on the luminal way, a block behind the below the knee. You see, 2 incidents, okay, to avoid the collateral artery, and we can move on with all what we see, soft wire in the collateral artery. This is what I do, but I prepare all that in the cath lab in case to escalade, which have the adapted coronary microcatheter. Okay, we move on. We start. You have the time position, you can look. Okay, I try to be straight. Seems good. Maybe a little bend. The angio. Not so bad, my friend, but humility, because no, the direction is not good, the feedback in the guide wire is not perfect, and I perform another angio. Okay, I do a dissection. No big deal. We work, we will start. 1 minute after, we redirect the guide wire with a little tricky. Now, I want to find the space. I'm sure there is a space to be in transluminal way. Okay, crossing time, 3 minutes. The angio, perfect, okay. But it was a failure with my microcatheter. It was impossible to cross this block. I can change for a long catheter, a long support catheter, but I was on a homolateral approach. It was too long. I used a coronary microcatheter. Oh yeah, for sure, it's not the same device. It's not also the same price. At the end, we move with the buccal system, POBA, atherectomy, up, and this is the final result. Little imaging, what is dissection, calcification, maybe I create, but the flow was good. I do another angio, and this is a post-operative CT scan. Pre, post. The result is good. And now, I can explain how could be the algorithm, and it will be my conclusion. Evaluate CT scan, CTO score, you choose your optimal access, you choose your optimal device. Reevaluate the distal and the proximal cap with 2 angio, small diameter, antegrade 0.14, antegrade, desescalade, success, treatment. And now we discuss a lot. When in 10% of the case, when we have a failure, we can use a double lumen catheter to find another way. An iVS catheter from the Japanese way, for me now, not a daily practice, but monthly practice, and to use also re-entry device. Specific cases, second attempt, iVS catheter in the cath lab. SFL without stump, it's the only way I prepare a retrograde access, because I want to be sure with an iVS to not dissected at the proximal part of the SFL to avoid the complication of the profunda. And when the collateral is occluded, for example, a huge occlusion of the common femoral artery, I use a double lumen catheter. Thank you very much for your attention. And I have another, can I have the last slide, please? You can go back? My conclusion? Yes. I was very interested yesterday by the topic. And I go to the computer last night, I open, I try to find the good answer. Did I convince Professor Ducasse to do a planning circle? Did I convince Professor Ducasse to avoid retrograde access? And this is the answer.
Very good. It's also the first time that I see Professor Ducasse doing like this. Yes. Thank you. Thank you very much, Nicolas, for this great talk. We're going to keep the discussion and the questions on tips and tricks up to the end of the session, because all the talks are a little bit in the same area. So my great honor to introduce Dr. Ida again, and we're going to see the Japanese strategy for below-the-knee revascularization. Please.
Okay, thank you, Chairman. Good morning, ladies and gentlemen. Here's my disclosure. First, Japan is a very specific situation because the frequency of diabetes and renal insufficiency on dialysis are relatively higher in Japanese CLTI population. These risk factors would influence the systemic and the lower limb and anatomical condition. So, in a clinical practice, below the ankle region and concomitantly treated the below the knee region. From our registry, which evaluates angioplasty for patients with CLTI due to isolated below the knee region, almost 60% of patients are complicated with a significant below the ankle region. So shown here is also a summary of the impact of the quality of the endovascular therapy for wound healing, angiosome theory, and the pedal arch angioplasty and wound brush. Indigo-calmia angioplasty are reported as a positive predictor for wound healing. So one of the controversial theory in infrapopliteal angioplasty for CLTI is the angiosome concept. To clarify this controversy, we conduct the warrior study. The main objective of this study was to overcome this controversy of the angiosome concept. The warrior study investigated whether the original angiosome-guided revascularization improved clinical outcome in patients with CLTI presenting the tissue loss. The study subject of warrior study were 440 CLTI patients with tissue loss undergoing revascularization. All bypass surgery was done using suspense vein graft, while all endovascular procedure was done using the contemporary technique and devices. Inclusion-exclusion criteria shown here. Evaluation of ischemic wound and infrapopliteal angioplasty lesion were conducted by independent and blind wound and angiographic collaboratory. Primary endpoint was complete wound healing. So whether the territory of the ischemic wound based on the angiosome concept matched a successful revascularization artery based on the completion angiography were evaluated collaboratively. If these were matched, this was defined as a successful angiosome-guided revascularization. This slide shows the main finding of the warrior study. 2-year wound healing rate was not significantly associated with the angiosome-guided and non-angiosome-guided revascularization in CLTI and tissue loss. The clinical question lies based on the result from the primary outcome. Does angiosome-guided revascularization equally mean the direct perfusion to the wound? So we conducted a post-hoc analysis. The member of angiographic collaboratory confirmed the wound location based on the wound photograph before revascularization and re-evaluated the completion angiogram with or without inline flow to the wound. Angiography direct perfusion to the wound was defined as a personalized angiosome-guided revascularization. As shown in this slide, personalized angiosome revascularization was consistent of direct revascularization and indirect revascularization with good collateral flow. The impact of personalized angiosome direct revascularization on the healing was evaluated at post-hoc analysis. As shown in this slide, personalized angiosome-guided revascularization had better wound healing rate. Interaction analysis shows that there are no interaction effect on the personalized angiosome-guided revascularization and wound healing. Approximately 6% of population treated the angiosome-guided revascularization matched the personalized angiosome-guided revascularization. So in the personalized angiosome direct revascularization group, incidence of wound healing was not significantly different between the patient with and without direct revascularization. So next topic is the below the ankle region. So how to optimally treat the below the ankle region. Key tips and tricks achieving the technical and the clinical success is shown here. As everyone knows, below the ankle artery are small in diameter and a high arterial torsicity. Therefore, wire with a specific characteristics such as a regalia, hydrophilic wire, and a sole are very useful for navigating these vessels. So as shown in this slide, the regalia and the sole wire is smoothly navigated through the lesion. After that, uniform balloon dilatation is performed from the proximal to distal portion of the lesion, starting from the normal looking to normal looking area. So here's a representative CLTI case with the below the ankle region. Initially, the posterior tibial artery, the lateral plantar artery were dilated by 2 mm balloon caster. But vessel flow to lateral plantar artery was suboptimal. Therefore, the entire region was additionally evaluated by iVS and dilated with a 2.5 mm balloon caster. So comparison of completion angiogram after 2 mm versus 2.5 mm balloon angioplasty for lateral plantar artery is shown here. After angioplasty with 2.5 mm balloon, inline flow from the posterior tibial artery to lateral plantar artery increased compared with the 2 mm balloon caster. So next, I'd like to discuss the indication of the below the ankle revascularization. So currently, global vascular guideline established an anatomical grade of the inframalleolar disease classified into the 3 groups from P0 to P0 to P2. The latest retrospective study revealed that inframalleolar grade 2 was independent risk factor for wound healing and male-free survival, demonstrating the GLASS IM grade 2 would be the surrogate marker for wound, limb, and patient-oriented outcome. More recently, there is a substantial controversy surrounding the additional below-the-ankle angioplasty in the patient with CLTI. As shown in the left figure, retrospective study reveals that the adjunctive pedal artery angioplasty significantly improved the one-year wound healing rate. However, recent prospective study demonstrated the potentially increasing the short-term amputation rate among the patients requiring intervention for below the ankle region, as illustrated in the right figures. So despite widespread the below the ankle angioplasty for treating the CLTI involving the below the ankle region, meta-analysis reveals that there are no statistically significant difference in the limb salvage when comparing the additional below the angioplasty to below the ankle angioplasty. This is a treatment course of the particular case. The initial treatment with angioplasty resulted in the complete wound healing, but over time, with the recurrence of the vessel condition, wound worsened, again, ultimately threatening the patient's lower limb condition. There is a limited available evidence which evaluated the factor associated with the worsened below the ankle region during the re-intervention. It is important to know that aggressive below the ankle angioplasty would lead to re-occlusion during the recurrence. So lastly, I would like to share the preliminary result of the below the ankle angioplasty focusing on the small artery disease and big artery disease, which are categorized beyond the pedal arch. Baseline distribution, the SAD score is shown here. Moderate to severe condition of the SAD was observed is over the 75% of CLTI requiring the below the ankle disease. So here's a comparison of the BAT, below a big artery disease condition between the timing of the initial and the re-intervention. Approximately half was a result in the angiographical worsening when re-intervention was done. So interestingly, in case with re-intervention, half was worsened from the stenosis to occlusion in the re-intervention timing. So when comparing the SAD score between the initial treatment and the re-intervention, there was a significant worsening of the SAD score during the re-intervention. So in this study, the predictor of the SAD progression was evaluated by multivariate analysis. As shown in this slide, treatment of the distal vessel in the foot region with a diameter smaller than 1 millimeter was an independent predictor of the SAD progression. This is a representative case with a SAD progression. As shown, the distal reference vessel diameter was smaller than 1 millimeter. The edge dissection occurred during the treatment of 2 millimeter balloon caster. During the recurrence, the SAD progressed. So maybe the further investigation will be needed to assess the true indication of the below the ankle region. So additional analysis was done. The impact of the angiographical worsening on the amputation-free survival, as shown in this slide, amputation-free survivors worsened in the case with the angiographical worsening. So in summary, the Warrior study reveals that personalized angiosomal-guided revascularization is very important to improve the patient outcome. And the specialized device and the knowledge and the mandatory for EVT for the below the ankle region. Additional below the ankle angioplasty is still controversial because there is an opposite study result. In some cases, with a small BTA diameter, below the ankle condition may worsen during the recurrence after balloon angioplasty. Thank you for your kind attention.
Thank you so much, Osamu, for this fantastic presentation. It's now the time for Agus to be back to talk about off-the-shelf DVA, how I do it.
Okay. So let me start asking you guys, how many of you in the audience have ever performed DBA? Raise your hands. 5%? 10%? Okay, let me tell you, for those who have not ever performed this before, that up to 20% of the patients who arrive to your clinics with a CLTI may be considered no-option guys, either because they don't have a target vessel to be just bypass or angioplasty, or because they have a failure of the distribution system, what we call the small arterial disease. And for these guys, who are basically condemned to a major amputation, DBA has brought some sprouts of hope, up to 60 to 70% limb salvage rates. But the most important thing when we are considering a DBA is to choose an appropriate candidate. We're not talking about a surgery in which that should be performed like immediately on the OR. Just take your time to assess the patient properly. Try to rule out any sort of huge infection or huge necrotic tissue, and always try to avoid the over-indication. This is super cool. Everybody wants to be the first one in the country to perform a percutaneous DBA, but keep in mind that if you fail, you have a 30 to 40% amputation rates. And also keep in mind that taking into account the psychological and social condition of your patients is crucial, because it's going to take up to 4 to 7 months to achieve complete wound healing, and you need patients committed with the treatment. So as you know, there is a dedicated device in the market, the lymph flow device, to perform the connection, but the main downside of this device is it has a low availability and an increased cost. And this made several physicians around the world try to develop different ways to perform off-the-shelf the connection. And as you also know, I come from a humble institution, and we also develop our own way to perform the connection, trying just to give physicians a low-cost way to perform off-the-shelf this connection. And it's really similar. So if you have been around here and coming from abroad, strongly recommend just to try this. This is the Spanish omelette. Just 3 ingredients: potatoes, eggs, and onions. And by the way, have you ever seen a cutest chicken like this? This is my daughter. So we also have 3 ingredients. We just use 2 snares, 1 wire, and a needle. And how do we make the connection? We use what we call the venous arterialization simplified technique with 2 snares. Let me show it. So if you're aiming just to perform a proximal DBA, what we basically do is to gain the venous access, and this is usually used, we use a tourniquet, ultrasound guided. This is the 2 veins next to the artery, and once we just perform the puncture, we progress 18 wire, and you can see the wire running nicely at the side of the calcified artery, and then we secure the access with a 4 French sheath. And thereafter, we progress our wire up to the ostium of the posterior tibial vein, and we perform a simultaneous fluoangio to look for the best spot for the connection. Once we are there, we progress a snare from the venous side, from the ankle, a snare from the TSL, from the groin, and then we put them aligned and parallel. And with a 21-gauge percutaneous needle, we just puncture through both the snares, like a gun-side approach. And as you can see, we progress 014 soft wire. You will see this nicely on this lateral view. And then we retrieve the needle, we close and retrieve the venous snare and externalize the wire at the level of the ankle in the venous side, and also we externalize the wire at the level of the ground in the arterial side. And we have this connection, and we secure this connection with balloon angioplasty. And look at this, no leakage, no bleeding at all. And then we secure the crossover point with a cover stent mimicking the lymph flow maneuver, and we flare the venous side. And also we prep the vein, the posterior tibial vein, with a 5 millimeters balloon, because this is going to lodge the self-expandable extension cover stent. And we usually use a bioband, a long bioband, up to the level of the foot. And once we have already deployed the bioband, we just need to gain access into the lateral plantar in order just to reach the forefoot. As you can see, this is the medial marginal vein and the great saphenous vein. We lodge the wire inside the medial marginal, and then we perform a balloon angioplasty to render the remaining valves at the level of the foot. And in case we had any sort of stubborn valve, what we basically do is just to inflate a cutting balloon or a scoring balloon and gently deflate and just pull from the groin in a sort of valvulotomy surgical way. And this is the final outcome. This is a nice, beautiful flow all over the graft in the lateral plantar and also in the plantar arch. But you may probably be thinking about why not to perform a distal DBA. I want just to skip all of these graft cover stents. Yeah, you can do it. What we basically do is just to get access again in the plantar vein. We gain access in the posterior tibial artery up to the non-crossable point, and this can be even distal at the level of the ankle. We prep the artery in order just to assure a good inflow. The two snares, one on the venous side, one on the arterial side. And again, we just puncture. We just double check that we have crossed through the snares. And then similar, like deploy your soft wire, retrieve the needle, externalize the venous side, and thereafter we just pull and externalize the arterial side and look the waist at the level of the balloon at the connection. So once we have done this, we just again need to gain access into the lateral plantar and the plantar arch. Here we are. And then in this case, we're going to just leave the wire on the anterior tibial vein, balloon dilation, the cutting balloon for the remaining valves. And look, this is the final outcome with nice breeze flow again in the artery, the connection in the vein, lateral plantar, and also into the plantar arch. And we usually like just to drain this plantar arch into the first metatarsal, just following the advice by Roberto Flores. It's like escaping for the forest. So this is a typical outcome of these patients. Like we have a worsening on the wound the first months, but at some stage we started to have some granulation tissue, and as you can see, at the end of the day, 8 months later, we achieved complete good healing. As you can expect, we were absolutely thrilled. And this is the current status of these guys. 2 years later, the patient is walking outdoors, still posterior tibial pulse, TCP2 quite pretty high, 67, and no recurrence. Why the VAS is our favorite technique compared with any other off-the-shelf or the lymph flow device? The main reason is because it's universal availability and low cost. It also allows you just to perform a puncture, which is not really technically difficult. We're thinking about 4 or 5 millimeters snare, and if you are used just to perform retrograde punches, this is quite easy peasy. This is no longer a blank technique compared with the strategy of just a curved catheter and breaking into the vein following the calcification. And really important point is you have an increased penetration power, which is a downside if you're just deploying your trigger from the groin with the lymph flow device or any other re-entry device. But the most important one for me is that it allows you to perform in a low-cost manner off the shelf either a lymph flow-like DVA proximally or a distal DVA. Definitely, this is a less codified technique if you compare with the lymph flow device. And with regards to reproducibility, I'm glad to say that this is one of the most popular maneuvers to perform off-the-shelf DVAs all over the world. And you may probably wonder, well, you talk about proximal, distal, off-the-shelf, lymph flow. What is the best choice? Well, if you have a look to this review from a Stanford, you will see that the wound healing rates and the amputation rates are pretty much similar. So probably has nothing to do with the way you make the connection. What is my advice? Try to tailor the technique to every specific case and take into account your device availability, your budget, your skills, and your personal preferences. So in conclusion, this is a promising last attempt maneuver for patients who otherwise will undergo a major amputation. Just keep in mind that we should be super rigorous in order just to think about the indication and with the proper follow-up. And raise your hands. How many of you are now willing to perform a DVA? I love you.
Thank you very much, August, for this very nice overview. So I think there are going to be a lot of questions, controversies, questions on technical tips and tricks. So please go on, ask for the microphone.
Ready for the first. Claudia?
Yes, Claudia already.
Hi, thank you.
Yeah,
Yep.
it's a...
Can you hear? Yeah. It's a question for all of you. I would like to know your personal opinion about intraoperative monitoring during this BTK, BTA. Do you have experience? What do you think? Is it going to be included in your daily practice? Any kind of intraoperative monitoring when you are revascularizing these patients?
Yes. So in Japan, Osamu, how do you do the intraoperative monitoring? When do you know when to stop, when to continue, if you did sufficient job or not? Do you monitor this during the case in one or another way? I know that you check very often with iVS the result of your treatment, but is there also something like perfusion, angiography, or whatever, transcutaneous oxygen measurement, pre, post? How do you measure this?
Basically, I think that angio is reliable. So we have many options, but I think the angio and the impression experience is very important. After procedure, we continuously perform the duplex ultrasound and the skin perfusion pressure every 2 weeks or every 1 month until the wound healing. This is our protocol.
And so with angio, you mean also the blush at the wound zone
Yes.
place? Yes.
Maybe the wound brush by using the DSA is one endpoint during the procedure.
Nicola, you are performing a CT scan post-procedure?
Only when I use the built-in system because of research. When they pass 3 hours, sometimes everybody is exhausted. We need to change the strategy. For us, the CTO of the SFR of the iliac artery is not majority of the case for limb salvage. We have the time to have another approach, but we never fail a lot at the end when we perform. But 3 hours, I think it's quite enough long procedure.
I had the honor, Mariano, to participate with you a few weeks ago, and I see that you're always doing systematically the pre and post perfusion angiography. Can you tell something more about this?
Yeah, honestly speaking, don't believe in this. It's iconical activity. More or less 1 year ago, Philips sent us a letter saying that this is not a good way to take clinical decisions. So we continue doing that because in any way you can see how you improve, but you never know if it's enough or not. So honestly speaking, I'm fully in agree with Osamu. I think the angio, the way you can see the flow arriving, how much flow is arriving, how much the vessels are working, because iVS or EVS are good to decide maybe how to treat or for some adjunctive therapy. But we don't really know an acute or intraprocedural way to test the patient. Or I don't know, if you do something different, Claudia, please share with us.
PAT measurements before and after? Is this a recommendation? Pedal acceleration times measurements?
We are increasingly using PAT, and this is definitely super cheap. We can assess the patient on the table, and if you just perform just recanalize one vessel, and probably if you're just thinking about DP or posterior lateral plantar, you have the wound blush, which is a good orientation. But let's say if you think about the peroneal artery, you don't really have a great blush. But if you have a PAT below 180, probably it's a good predictor of wound healing.
Lieven also has a question.
Yes, I have a technical question regarding the metatarsal punctures, because for me it's already challenging to go into the plantar arch. So for people who have no experience, how do you approach? Is it purely on the calcium you see, duplex or angio? What vessel do you target? Where to start?
You're talking about digital arteries?
Yes, yes.
Well, in our experience, digital arteries are not really nice to or easy to approach, ultrasound guided. And usually when you punch a distal vessel, calcium is your enemy. But when we're thinking about digital arteries, is your ally. Because if you want to perform this on the rod mapping, this is really a pain because you need just to perform some dorsiflexion of the foot in order to have a good incidence angle of your needle. And then if you move the foot, you spoil your rod mapping. So calcification for a plain X-ray is the best way, in my opinion. But Mariano, we learned this from Mariano.
Calcification is the first way to do that. It's very easy. The first metatarsal angio, when you put the foot in the anteroposterior view, is clearly in the middle of two bones, the first and the second toe, so it's quite easy when the artery is calcified. As well, you can do it under ultrasound. I have a couple of cases in which I puncture the first and the second. The time I punctured the second was trying to puncture the first, but I was wrong. But I was able to see it under ultrasound. However, as I said, in my mind, this is one of the last options when I need to arrive in the arch or when I need to improve the flow for the forefoot. But yeah, and the fluoroscopy is the most frequently way to do.
And before you puncture, you do any vasodilating therapy, or is not necessary?
When we start to do this with Marco, we published to inject vasodilators, to use verapamil in the subcutaneous tissue around the artery. Finally, we realized if you are using calcium, you don't need vasodilators.
Good. Our artificial intelligence example, Professor Ducasse wants to ask also a question. Can we have the microphone there?
Oh, thank you. I don't know what it means, intelligence, but anyway. This is for all of you guys and maybe more for Osamu and the Japanese school. To mention what Claudia said, that was PERP. But after the main question, the main concern, this is how to follow very carefully all those treated patients. Shall we put patients in a very specific algorithm or a program of to make re-angio and the repetitive angio and repetitive treatment? This is a main concern, or is it just a clinical follow-up of patient and the wound healing?
For me, as a vascular surgeon, I'm happy when my patient is happy. And my patient is happy in two conditions. Yes. If the rest pain or the wound is healed and the rest pain is gone, and he doesn't need to come quite often for re-intervention. These are the two criteria for happiness, in Belgium at least. I don't know, in Japan, do you follow up your patients in a more, let's say, profound way, also to check on a regular basis the patency?
Yes, I think it's depending on the patient condition, but basically the indication re-intervention is clinical driven. If the patient has a restenosis, but the patient is very happy, we never intervene. But I regularly perform the duplex ultrasound and conditionally the skin perfusion pressure to assess the decreasing the ischemia or not. But anyway, the duplex is standard.
The wound is healed, your revascularized vessel is occluded on duplex ultrasound. You're going to re-intervene or not?
No, never.
No. Okay.
We also follow them clinically driven, but I want to ask you guys, because we're not really as stenters guys on the BTK vessels. So this would be different if you have deployed a stent in the BTK vessels?
For me, yes. I mean, sometimes when I notice that proximal stent is starting to restenose actually, and we are reaching a restenosis of more than 70% before it occludes again. Sometimes I go back and try to keep it open.
And also if the patient is
No, it's different for me because we have a very important clinical follow-up. I mean, the patient is back to do a duplex when the patient manifests any new or not any changes in the clinical baseline condition. So the time I realized the stent is not functioning,
it's too late.
Yeah, it's too late. Honestly speaking, it's late.
At the end, it's working with a team. You have the wound healing center, not the referrer. You have the angio. You need to have all the personnel with you because we can follow up every patient.
Yeah.
More questions? Yes, please.
What adjuncts do you use to heal the wounds? Maybe Claudia can answer the question. Ilioprost, hyperbaric oxygen therapy, ozone, magic, oils, prayers. What do you guys use?
Yeah, good question. I mean, wound therapy in general is, at least in our service, a very personalized and patient and lesion-tailored, especially lesion-tailored approach, also very dynamically. So it's changing, and that's the reason that as long as the patient has a wound, that almost every week he's coming to our wound clinic to look, seen by our wound care specialists and podiatrists, if we need to change the bandage. And this is quite often from hydrogels to alginates, negative pressure therapy, of course, in the beginning, if we are speaking about extended wounds. But yeah, there is not really, at least not in my service, a golden standard way of performing. We are most of the time using the quite old-fashioned time principles, tissue, infection, moisture, and edges. Still, we are using this criteria. I don't know, my colleagues.
This is really important. I think teamwork is essential here. You can spend like 3-4 hours trying to recanalize the arch, but if the wound heal, the dressings are not appropriate, all of this. So once happened to me that 3 hours to recanalize the arch, we send the patient for a TMA amputation, and the fellow chopped the arch. So as you can imagine, I was super excited.
Yeah,
I chopped the fellow.
Okay, guys, the time is finished. So let's say thanks to all of you, August, Osamu, Luis, and Kundelus, to be here. It was a pleasure.
This is all open now. Congratulations. Great job. Congratulations. I like your B. Yeah, fantastic. Yeah, perfect.
Maybe I will update the data until the next click.
Okay. Fantastic.
We will see, because I don't know the cases.
Okay, me neither. No, I have no idea. So let's go.
Yeah.
Where do you want to see?
As you like.
We sit
Okay?
together.
Okay, good.
So let's start with next session. It's going to be clinical experience exchange. It's session number 2. So we have different topics, different talks. Let's start with the first one is AV fistula. Dr. Benjamin Sevenin starting this session.
Yeah. You are the first one?
Yes.
Yeah.
Okay. Ready to go. So now, after each case, obviously, if you have questions, we can address to the speaker, and we clarify a little bit better any question.
So thank you for the invitation, and I think it will be the only 5 minutes to speak about something very different, not this beautiful case of aneurysm, distal revascularization, but something more usual and very atypical. It's arteriovenous fistula. So in 5 minutes, I have to explain this beautiful therapy, this something it's totally unusual, it's artificial, with a high rate of stenosis. And unfortunately, we have direct sanction. Stenosis, no dialysis, you call your friend the surgeon. So this lesion have some specific technical issue. We need to evaluate your actual tools. First of all, navigation. Sometimes it's very easy. Direct punction of your fistula, angiogram, you see the problem, up, just here. Direct crossing, good result, even if there's a little exception with this ligature of the distal artery. Sometimes it's less easier, and I won't do like Nicola. It's impossible to make little circle to see this lesion. So something very easy, it's direct ultrasound navigation for this kind of lesion. With this little tool, it's very easy to cross your lesion, to see the stenosis, see the collateral, and with a compress, when you use your sound to compress your vein, you direct your guide wire in the anastomosis to practice the appropriate therapy. And last but not the least, with this unnatural configuration, it's very important to have some tools to cross this kind of lesion with very sharp angulation and to have a good balloon to push the appropriate impression of the other lesion. When we cross the lesion, what kind of lesion? This classical fistula in the forearm, okay, the duplex say 3 lesions, but 3 different lesions. First one, paraanastomotic lesion, due to the modification of the vein, to the reduction of the flow, and in half of the time, due to the presence of a valvule near the anastomosis. One type of lesion. Second type, puncture seats, direct traumatism, 3 weeks, no good. And last, but not the least, due to the vein, one single system, 3 types of lesion. Okay. One treatment, dilatation, but do we have any other tool? No. Balloon, drug-coated balloon, and quite at all. Sometimes with more specific lesion. This example, we have a very thin stenosis in the valvule in the drain, in the venous drain. Balloon, high-pressure balloon, scoring balloon with big traumatism of this vein. Not good, but direct result is good. And even in the artery inflow, for example, in this kind of stenosis with a less of maturation, you can improve the arterial inflow with increasing the size of the artery. No specific stenosis, but when you use bigger diameter balloon, you can improve the flow in your fistula. So different lesion, one tool. But what's the result? Classic fistula, 2 stenosis. Unfortunately, it's not the first time. We already practiced classical angioplasty in this one 8 months ago. Direct crossing, nice result, good inflation, 5 minutes, 10 atmosphere. And here, no direct stenosis, but direct traumatism. As we know, with this kind of traumatism, there's a large risk of hyperplasia. Here, it's easy, you see it, but with a perfect image, you have the same result. Direct traumatism, high risk of hyperplasia. And what's your weapon? Stent? Not in this way. Bare metal stent? Whatever you want? No. Drug therapy? Yes, we've got it. So actually, there's 2 therapies who have been tested, the Lutonics with the BARD and the impact. What else? Here is with the vascular. And so in my institute, we try to say, okay, what new therapy? During 1 year, we treat 53 patients, any kind of fistula, direct fistula, graft fistula. The only limitation was the size of the balloon we have to use to treat the stenosis. All kind of localization, paraanastomotic, seat puncture, graft anastomosis, and even central vein. And after 1 year, good quite primary patency, 60 primary patency at 6 months. It's the classical rate for this stenosis. Reintervention after 8 or 9 months, surgery, or even another dilatation. That's why after this little thing, we try to make Lumifab. Lumifab to test the performance and safety of Luminor in arteriovenous fistula stenosis. The primary endpoint will be the primary patency at 6 months, and the second objective, the safety clinical performance area, and at 2 years. Actually, it's a retrospective motor-center, single arm, and single surgeon. And normally, the next result of this Lumifab will be shown in September, maybe with the next multi-center study, I hope. Thank you for your attention.
Thank you. Any question? I have a question for you. Do you use the DCB either in the arterial or in the venous side?
Yes, both sides.
Both sides. Okay. And which kind of access do you use generally? The arterial one, you work on the venous, or you do a
It depends on the localization of the lesion. First, I practice myself my ultrasound to guide the punction seat, and most of the time it's a venous transcollateral vein approach, so that if I destroy the little collateral, it's not a problem. Or if it's too approach from the anastomosis, sometimes it's direct humeral punction with arterial localization.
Good.
And I have another question. Do you have any protocol to follow up them? And what's the medical treatment after that? Because these patients normally receive also heparin intradialysis.
Yes. Hopefully, all of these patients are quite the same therapy with single or even dual antiplaquetal therapy. When it's restenosis, quite restenosis, I use dual antiplaquetal therapy, statin 2. And we have the change in my institution that there's quite a lot of patients with one center and one duplex. This is only one radiologist who practices all the exam of the fistula with a very strict protocol, 2 weeks, 1 week, and at each dialysis. If there's any problem at any time, there's one paper who is called, and it's me. So there's a strict reactivation for this. Thank you.
Thank you. So if there are no other questions, thank you.
Thank you.
And we move forward to the next speaker, is Dr. Encarnacion. Is good? Okay.
Yeah.
It's a single pedal access for treatment of inflow and outflow in limb salvage. Please.
Hello, good morning, everyone. For me, it's a great honor to be here with you. I want to say thanks to eVascular for this kind invitation. I'm going to talk about a really interesting topic because, as you know, as the recent release trial, BCLI, and also the basic tool CLI, endovascular therapy continues being the gold standard to treat patients with high risk and with CLTI. And the common femoral artery is the most common use, but it has some disadvantage. Like, for example, in patients with groin infection or obese patients, the risk of complication increases significantly. And also, the tibiopedal access is a technique very known in the world and very used. For example, Dr. Palena wrote about the Presto technique by releasing a stent from below when you have ostial SFA occlusion. But when talking about treating the inflow and outflow, the fact is that there is not many data published. So I want to present to you this case. It's a female, 16 years old. She has history of high blood pressure, smoking for more than 30 years, and she came to us with a rest ischemic pain in her left foot. She had an ABA of 0.4 and also on the physical examination with no pulse in tibial and popliteal artery. So we performed this angio-CT. As you can see, she has ostial occlusion and very long occlusion in the SFA. And for that reason, we plan to do revascularization to the posterior tibial artery. So we did a sonoguide puncture of the posterior tibial artery. And as you can see in the arteriography, there is a near occlusion stenosis in the proximal segment of the anterior tibial artery. And as was shown in the CT scan, it is long occlusion of the SFA, ostial occlusion, in fact. We could cross this lesion using a common wire and Sargent catheter without any difficulty by true lumen. So we did angioplasty, predilatation, using 3 millimeter oceanic balloon and then 5 millimeter oceanic balloon. This was the result after the angioplasty, and then we put a self-expanding bare metal stent, proximal and distally. As you can see here, we have Evolution Pro in the distal part of this occlusion. And this was the result after a stenting. And we have this. So I want to ask the auditorium here, in this case, at this point, would you do anything more in this lesion? I want you to raise your blue card, if you do anything to this anterior tibial artery. Who will do anything to this anterior artery? Nobody. Neither me will do anything, but my team was pushing to do anything more. So this case was resolved relatively quickly, so I was happy to do anything more. So I use a TIG catheter and also a Sahi regalia wire, 014, and we could cross to the anterior tibial artery, and using a coronary balloon, we did an angioplasty here, and this was the result. We got pulse immediately after the procedure and really good inflow, and listen to that sound. It's like to listen a saxophone behind a sky full of stars beside you, beside the girl you love. It's really amazing to listen the sound after an angioplasty. And this is 1 month follow-up of the patient, and the 6-month follow-up, we got pulse and also ankle brachial index on 0.9. So in conclusion, retrograde pedal access is safe and effective to treat long and complex CTO inflow, but also can be used to treat outflow vessels in some patients. It decreases the time amount of contrast needed to compare with femoral access, and also complications related to access are very rare. And the most important thing is the low profile of the vascular products that can be accessed to a 3mm vessels, and you can treat also iliac disease in some selected patients. Thank you very much.
Wait a second. Any question? Let me ask you something. Why do you use such a long stent on the FemPop segment? Because it looks that also with a simple angioplasty, this could be fixed. There was not a huge amount of calcium, just some spots.
Well, the reason that I use a long stent was because of the lung of the lesion. Yeah, as you saw, there was a really long occlusion of this FA.
But, also for long lesions, we can do, simple angioplasty. Maybe you can use a DCB, combine, and use a spot stenting. So this is something. Which kind of therapy do you use after the treatment?
Dual antiaggregant therapy, clopidogrel and also aspirin, and cilostazol.
So double for how long?
Double for 1 month, and then
4 weeks. Okay.
Yeah.
Good. Other question? You have a question?
And do you check if the response to this antiplatelet therapy, there is some resistance in some patients, clopidogrel especially. Do you check in general in your patients when you give dual antiplatelet, or?
Well, basically, I haven't had any experience with a resistant clopidogrel. All my patients respond very well with those therapies.
Okay. And another question. Normally, when you use this retrograde access, do you prefer sheathless, or you use a sheath, or how you close your puncture just by angioplasty compression? Do you have any algorithm or protocol for that, or?
Yeah, I usually use a slender sheet with a low profile, and also we put a cocktail with after the sheet. And when we do only single pedal access, sometimes you combine, maybe if I use femoral access too, I sometimes use sheetless techniques, just puncture and recuperate the wire above.
Okay. Good. Thank you.
Okay, Mark.
So I introduce next speaker is Dr. Takuya Haraguchi, the rendezvous pierce technique.
Okay. So, ladies and gentlemen, this is Takuya Haraguchi. So, from Japan, from the other side of the earth. So, I just shared my CLTF case. I must be the CLTF, Japanese CLTF fighters. And I just shared the complex calcified region case and shared my random pierce technique to solve the calcified region. Okay. So, please enjoy. So, I'd like to briefly introduce the case. So 68-year-old male without hemodialysis patient, but with severe diabetes patient, presented with the ischemic rest pain. And the angiography demonstrated too bad angiography. So, and it seems to be a disaster, such as a catastrophe. So, but I'd like to treat, I have to treat this patient. So, okay, so angiography is demonstrated, right? These are SFS, CTO, and BTK 3 vessel disease occlusion with a severe calcification. And but fortunately, the slight contrast effect was observed at the distal PTA and from distal ATA to the dorsal pes artery. Okay. So I first introduced the 6 French guiding shears from CDFA ipsilaterally. And firstly, so I treated distal SFCTO using a scaffold and balloon angioplasty for the PTA. PTA seems to be much easier level than the ATA severe calcification occlusion. But rest pain and cyanosis remained due to a very poor vascular bed. There are no collateral from the plantar to the toes. So therefore, I decided to treat the ATA CTO. So firstly, antegrade guide wire was advanced in the middle of the CTO, but the microcatheter could not cross the proximal ATA's calcified rock. So therefore, I decided to perform retrograde approach, and the device guide wire, regalia and carnium were inserted via dorsal pes artery. But both guide wires were advanced into the middle segment of CTO, but the microcatheter cannot cross the proximal ATA and middle ATS severe calcified rock. So therefore, I decided to perform the random pierce technique to modify the intimal calcification in the proximal ATA. So after the local anesthesia, a 20-gauge needle was inserted and advanced to the target is the guide wire tip. And then the antegrade guide wire was advanced into the needle's lumen to externalize the guide wire, named needle rendezvous. We already published it. And then the needle was introduced over the externalized guide wire with wire tension. And I manipulatively repeat rotate and cross the target calcified region like this. Seems to be a little bit dangerous, but it's my technique. Okay. So after that, like a rotabrator. And then, so 2.5 Oceanus successfully crossed and dilate the proximal ATA. And then, so retrograde guide wire advanced and cross that proximal ATA calcified region and advanced the guide wire into the guiding sheath to perform the complete externalization. Finally, 2.5 Oceanus across and dilate the entire region like this. This is the final angiography. Angiography demonstrates successful revascularization without any complications, such as hemorrhage from the rendezvous pierce site. This patient's symptom improved, and no symptom remained at 6 months follow-up. This is the final slide. So random pierce is useful for the modifying complex calcified region during CTO wiring. And Oceanus and Sargent are produced by the iVascular product that has a very nice crossability. And these devices are helpful in crossing complex region. And my rendezvous pierce techniques seem to be a little bit complex, but that is simple. So therefore, if you perform this technique in your cath lab, your colleague said, what are you doing? So please say, don't worry, I'm just puncturing with needle. Thank you so much.
Any question? Yes, August?
Thank you very much. I must acknowledge, I must give you all the credit because we tried the inner peace technique like 2 months ago, and it basically works. It is, as you mentioned, it's not as difficult as as you have said. I would like just to share with the audience some technical tips. So what sort of wire you need? You don't really want to use a coated wire. Do you pull from both sides just to straighten the wire and just to allow the needle to progress? So can you just like elaborate slightly the technique?
Okay, thank you so much. So basically the needle hole, needle lumen is larger than the usually used micro catheter. So therefore, if you are used to the rendezvous technique, everybody, you can do it, the needle rendezvous. Okay, and 18 gauge needle, so in this case, I use a 20 gauge needle. 20 gauge needle's outer diameter is 0.9 mm, and the 18 gauge needle's outer diameter of 1.3 millimeter. So therefore, it depends on the region characteristics. You should select the 18 gauge needle or 20 gauge needle. And I think that the puncture angle is very important. So therefore, I recommend the less than 45-degree puncture angle is very safety to prevent the vessel injury and any complications.
Yeah. So you know these needles are quite sharp. The total circumference of the tip. Do you have cases where you cut the wire with your needle?
Thank you so much. So some Japanese doctor experience the guide wire cut, but so I already told you the less than 45-degree puncture angle. So I recommend the 30-degree puncture angle is much safer to prevent the guide wire cut and vessel injury.
Good. If there are no other questions, thank you.
Thank you so much.
Now you?
Yeah. We can move forward to the next case. Is Dr. Konstantinos Tichiropoulos, more or less, is going to talk about a fever repair of pararenal aneurysm.
I would like to thank, first of all the scientific committee and iVascular for kind invitation. So we'll talk about fever repair of a pararenal aneurysm. So with a man 76 years old, his medical history was hypertension, atrial fibrillation, dyslipidemia. He had a coronary artery disease with a percutaneous coronary intervention in 2014, peripheral arterial disease, and endarterectomy of the left common femoral artery with left external iliac artery stenting. He presented with a pararenal aneurysm of 55 millimeters, and the special was that he had an anatomic variation with a common origin of the celiac trunk and the superior mesenteric artery. As you can see in these sagittal views, there is the common trunk, and then the division to the celiac artery and the superior mesenteric artery. So, under general anesthesia, we had a surgical cut down of the common femoral artery, systemic heparinization, all the stuff with the endovascular procedure with the specific devices. Due to his anatomical variation, we preferred a custom-made endograft with 3 fenestrations from Cook, advanced from the right femoral artery. A Gord dry seal 18 French was advanced from the left common femoral artery in order to proceed to the, this is, you can see the device and the proper orientation in order to deploy it. And catheterization of the target vessels with sterumosoft guard wire and flexor sheath with the help of the RDC catheter to both renal arteries and a rim catheter due to the presence of the ankle in order to advance our wire to the celiac artery and the SMA trunk, which was exchanged with a rosin wire. So we mold the proximal part with a Raelian molding group, and then we advance to both renal arteries an I-cover B graft of 8 millimeters and 37 millimeters length, and then to the common trunk of the celiac artery and superior mesenteric artery, and then 37 I-cover B graft. We flare all proximal parts of the I-cover graft with an ultraverse balloon 12, 20. The final images, final angiography, total radiation time 140 minutes, total radiation time 26 minutes, the contrast amount 200 ml, The patient discharged the third postoperative days under Eliquis, lifelong term due to the atrial fibrillation, and aspirin for 3 months. You can see the perfect patency of the grafts together with exclusion of the aneurysm. At 6 months follow-up, there was an exclusion of the aneurysm sac with no presence of an endoleak, and the big grafts in the celiac trunk and the both renal arteries were patent with excellent flow to the target organs. So in conclusion, fever repair of complex aneurysms with a new generation covered stent graft is feasible with very good results. This new generation covered stent provides excellent trackability, stability, and visibility during operation. However, multi-center studies with the use of such grafts in complex aneurysm repair are necessary to provide their long-term efficacy. Thank you for your attention.
Thank you. Any question? Can you explain which are the technical characteristics of the eye cover if you compare to the other cover graft that are... The technical characteristics, you know?
The technical characteristics.
Yep. Which are the advantages, you know, because
according to our experience in Thessaloniki, we have used some other grafts like big grafts. The basic difference was the visibility of the graft. We had a great difficulty when it was advanced through the graft, through the fenestration, and the marks. And during deployment, we have the tendency to see very good the marks, both distal and the proximal, and to be, of course, a safe procedure for the patient. This is the basic thing.
Yeah, and
despite the fact that big grafts, for example, have a 1/10 smaller size than eye cover grafts, we don't think that this is not a serious problem because the visibility of the stent grafts is more serious than the French size of the sheath.
Yeah, I think also this is another big deal also in terms of access because, you know, this is not compromise the procedure.
Yes.
Any other question?
Well, I have just a doubt. I found quite curious that you do a cut down. Is it your regular practice or you, because normally the risk?
Our daily practice is to perform surgical cut down. We don't have a lot of experience with percutaneous devices, but we think if something goes wrong, open surgery remains the best way to treat a patient. You know that the left side was we had a previous operation with an endarterectomy, so it was too difficult to dissect.
Was difficult.
Yes.
Yeah,
with the patch, with the bovine patch on the common femoral artery, so we prefer to perform a surgical cut down of both sides.
Yeah, no, well, because risk of infection is a bit higher, and the redo sometimes here.
Sometimes, but not always.
Okay. Congratulations for the case.
Okay, thank you.
Thank you.
So let's move on to the next speaker, IBD case, Dr. Bernard Peters. Thank you.
Hello, everybody. I would like to thank iVascular for this opportunity to present to you a case of an iliac and hypogastric aneurysm in which we use the eye cover stent for the stenting. Now, my case is a 71-year-old male who has no vascular history. He's actually still a very active man who likes to walk, who likes to bike around, and has actually not a lot of comorbidities, only arterial hypertension and some hypercholesterolemia. As you can see on the image on the side, he has a normal aortic diameter, but he has two iliac aneurysms. On the right side, it's only 19 millimeter, but on the left side, it's starting to grow quite big to 35 millimeters. This is the CT scan. You can see from the infrarenal aortic proportion is quite normal. Then you will see on the right side, there is the iliac is ectatic, but on the left side, it's getting quite big. And on the hypogastric arteries, also on the left side, aneurysmatic until quite deep into the pelvis. What should we do? There are some options. First of all, follow-up seems to be a very good option. I looked up the new 2024 aortic guidelines, and the recommendation 135 has been changed, which means that the ESVS recommends the treatment or the elective treatment of iliac aneurysms only starting at a diameter of 40 millimeters. We can do an open approach. We can do an isolated IBDs, which I don't think is the option here because there's no good proximal seal in the iliac arteries. We can do an EVAR or an IBD, or maybe there are other suggestions. Well, our treatment approach was because we did the treatment because of rapid growth of the left iliac aneurysm. The right side, we decided there was a good sealing zone in the common iliac artery because we want to preserve as much the hypogastric arteries on both sides. On the left side, we had a large aneurysmal section of the hypogastric artery, so we decided to place an IBD on the left side and go for a good landing zone in the external iliac artery. So we planned an EVAR with a left-sided IBD. Here you can see we went for a procedure, was a bilateral percutaneous access in the common femoral artery. Here you can see the angiogram of the left iliac artery with the aneurysmal hypogastric artery. We advanced and deployed the IBD, the Cook IBD, and then did a crossover with a 12 French sheet until we got into the branch of the IBD device. We did the cannulation of the left hypogastric artery, which was quite easy because it was quite broad. We changed for a Rosen guide wire to have enough support. And then we decided to advance 3 eye cover stents. We did the 9mm distal. You can see one over here. This is the first one we were advancing quite deep into the pelvis to have a good seal. Then we placed the second one, another 9mm in the middle, and then a proximal one was a 10mm to get a good seal in the IBD. This is how it looks like. This is the completion angiogram after placement of the IBD, and you can see a very good result. We have a very good distal seal, we have a very good proximal seal, and also in between the stents, we actually have a very good sealing. We went on to place the complete EVAR construction, and this is the final angiogram, which you can see there is no endoleak in the left common iliac artery, nor in the hypogastric artery. The patient actually had an uncomplicated postoperative course. He went home after 3 days and was very happy. 1 month follow-up images. You can see them on the left here. We have a very good proximal and distal seal. There's a small endoleak at the aortic bifurcation, but actually no endoleak in the left common iliac artery or in the left hypogastric artery. And we see a patient that recovered very well, but even with the IBD and the hypogastric preservation, he still has a Rutherford 2 gluteal claudication or butt claudication on the left side, which we hope will recover quite fast. So the conclusion is 2024 ESVS guidelines have changed their diameter for elective treatment of the common iliac or iliac aneurysms, starting at only 4 centimeters. EVAR plus IBD is a good option for elective treatment of iliac aneurysms. The 3 consecutive covered stents are feasible and give a good sealing, and actually the trackability of the eye cover is very well, and here you can see the end results. Thank you very much.
Very good.
Yeah, I have a question. Do you normally, I know the behavior is very good of the stent, especially in tortuous areas, but do you normally check in different projections at the end to see if there is any kinking or something, or your distal landing zone of the stent, if it's in a narrow or you know, in a flexion area, or do you do a combined CT scan afterwards, after the procedure?
We don't really do a completion CT scan after the case. We do use a 3D reconstruction to have a very good preoperative image of what we want to do and where we want to stent, so we can have a very good landing zone deep into the pelvis.
Okay, but you don't double check just at
Not
the
really.
end before, you know, finishing the procedure to
Well,
see if you have to extend or...
We checked the angiogram and there was very good flow, so we were actually quite happy with the results.
And what about the medical treatment after the procedure?
We give dual antiplatelets for 3 months, and afterwards just aspirin.
Okay, thank you.
Let me ask you something. In the image that you showed, seems that on the left side, you can patent the anterior and the posterior branches of the hypogastric, or you sacrifice one of them?
We sacrificed one of them because there was one of them was very close to the aneurysm. So we decided to overstent that one. And actually, we do quite a large balloon expandable stent to be sure that the ostium of the branch was occluded, not to have an endoleak afterwards.
You sacrifice the anterior? If
I'm sorry.
Okay. Do you think that also in this case, that is a more than 70 years old guy, could be necessary to do also an EVA, or you can also treat this one with an isolated branched stent graft for the ilia common and the hypogastric?
Well, I think for the isolated IBD, there was not a good sealing zone proximally in the common iliac artery in this case, so we went for the EVAR plus the IBD case because of the proximal seal.
Because generally we prefer, especially when the aorta is normal, just to fix, where there is the disease. So it's not necessary to go up to the abdominal.
Okay.
Okay, thank you.
Thank you.
Last case? Okay. We have now an AV fistula rescue. Is Dr. Marin is going to present
thank you.
I suppose, interesting case.
Thank you. Good afternoon, everyone. It's afternoon now. Let's move forward. This is a female, 27 years old patient with hypertension, diabetes, chronic renal failure since 7 years ago in a hemodialysis program 3 per week. Multiple hemodialysis catheters, implantation in jugular veins, both jugular veins, and both subclavian veins. Obviously, this moved the patient to the central venous occlusion, the chronic venous occlusion of the femoral and iliac right side. Do the DVT for catheters too. It's a very complicated patient. And I did an epigraph in the left side 2 years ago. I can say this is a high-value vascular access. Now the patients come to the consultation with multiple graft pseudoaneurysm, in particular one that concerned with symptoms. And this is the image of the pseudoaneurysm. So the initial approach was a puncture with a 6 French introducer in the graft, 0.35 wire terumo. And I thought that with a night cover 6 by 37, maybe I can solve the problem. The procedure was performed a few weeks after the planning, so I found a different thing, and you're going to see. The final material used was a night cover 6 by 57, by 37, and by 17. Why? This was maybe I can solve, not this with a 37, maybe with a 6 by 70, by 57. I move forward to do it. The deployment of the stent, and this is the result. In this proximal part, I probably need to cover with another stent, and this maybe can solve with angioplasty with a bigger balloon, I thought. And this is the result after the deployment of the proximal stent. We have a leak, obviously, right from here, and balloon, 7 millimeters, maybe the leak can resolve with that. Bad news for the insurance company. Another stent, maybe cover this part, and a 6 by 17 balloon was releasing, was releasing this part, and finally, I have a result. Thank you so much. That's all.
Thank you. Questions? Let me ask you something. How much of a size do you generally use in the veins?
This was not a vein, it's a graft.
Yeah,
6 millimeters in the veins. Maybe I can oversize 20, 30%.
Okay.
Yes.
That's different. Okay. Just a couple of questions.
Congratulations, Andres. Just forgive me because I have no experience at all about that. But these sort of endoleaks could be sorted out in a low-cost way, just with some injection, or it's not really something that you should recommend?
I can't hear.
Oh, sorry. No, I'm just saying that if these sort of leaks following this could be sorted out with thrombin injections in a low-cost way, or not? This is not a safe recommendation.
Yes, probably, but this is a high value. I don't know. I don't have more sites to place to perform another AV fistula. If I lost this fistula, the patient was very complicated and maybe lost the life. I was wondering this works well, and I talked with some friends, and in the insurance company get covered, and that's the way. The patient is going well since a year, more or less, and there is no pseudoaneurysm now, and the fistula is working. For this kind of patients, that is a high value. I think so. Maybe.
Yeah.
Yeah. Thank you for the case. I have two questions, actually. One is, why wouldn't you do a surgical repair of the graft? Just cut down, replace the part of the graft that was disrupted, and do a terminal anastomosis on both ends. And the second is, are they allowed to puncture the graft at the place where you did the repair with the stents or not?
That's a very good question. And surgical approach is correct. Maybe it works better than this. I agree, maybe. No, I do not recommend to puncture the stents per se, but my recommendation is not following in all the cases. Maybe the nurse, I can say, don't puncture here or here. The nurse maybe do it, maybe don't do it, but at this time, I probably think the stent was punctured, but the last week, I saw the patient, and the patient is going well. The aneurysm, the pseudoaneurysm doesn't appear again.
The last question?
Andres,
yes.
Didn't you think to use another stent like Viavan? Easier?
I don't have Viavan.
Ah, okay.
In Dominican Republic, I just had these 3 stents in the cath lab that day. Maybe I can put another longer stent, but that's the stent that I had. I don't have Viavan in Dominican Republic.
Okay.
Go hate us.
Okay. Thank you.
Thank you.
Thank you.
Okay.